10 little fingers and 10 little toes. The birth of a new baby brings so much joy. On today's show, what doctors and nurses are doing right after your baby arrives that could impact their future health. And good morning. It's Friday, September 2nd. I'm Jessica Lovell. Welcome in to the Morning Medical Update and into the Dolph C. Simons Jr. Family Broadcast Studio. Coming up today, advice on avoiding COVID this Labor Day weekend. 34 tests Kansas newborns take and why. Plus, the University of Kansas Cancer Center gets a big honor from the governor of Kansas. Our experts today include Dr. Mike Lewis, medical director of the pediatric inpatient and intensive care units here at the health system. You're also pediatric cystic fibrosis program director, and that is why we have you here today. So glad to have you as well. And we also have Dr. Kourtney Bettinger, who is the medical director for the KDHE newborn screening follow-up program and a pediatrician here at the health system. So please send in your questions to us. We will get to those here a little bit later. You can send them on YouTube, Facebook, and the Medical News Network. The links are right there on your screen. Each year, more than 40,000 newborns in Kansas undergo their first thorough medical checkup before leaving the hospital. Why? Doctors are screening for genetic, metabolic, blood, or hormone-related issues that could pose future health threats. September is Newborn Screening Awareness Month. Jill Chadwick caught up with infant Emily Hare as she was being screened.
This is likely not how 2-day-old Emily planned her big entrance into the world. That's not a hunger cry. Instead, Emily is responding to being screened for genetic, developmental, and other potential health disorders.
So we always start with, of course, which baby we have, when we get them out of the room, and then when we take them back into the room.
On this day, Emily will be checked for 34 different conditions, just like all newborns in Kansas, where more tests are performed. Nationally, 5 fewer screenings are performed according to the National Institutes of Health.
And so Morgan's gonna kind of start unwrapping her, and she's gonna put 2 heel warmers on her foot.
So what exactly are these nurses testing for? They are seeing if newborns have one of many conditions, including any amino acid disorders, problems with their thyroid, hearing loss, and heart problems.
Get set up for a poke.
For this round of tests, these nurses are using the blood from the heel. The blood is then collected onto a special paper and sent for testing.
You're probably gonna have to poke her twice anyways.
We'll see
Sorry.
if we can get this one first. That's okay.
According to the NIH, 4 million infants every year in the U.S. are screened.
We do this in 5 different spots.
And so she's 10.8. Any baby above 8, we have to draw what's called a TSB on.
The CDC says these screenings have discovered that 1 out of every 300 newborns are found to have one of the tested conditions.
I'm so sorry,
It's an apology that isn't necessary, as these tests get Emily off to a healthier start in life.
I have to say that was one of the questions I guess I forgot to ask, and I had no idea when I had my kids that they were off doing all of these tests. Certainly glad they were. So Dr. Bettinger, I want to ask, states require newborns to be screened for different things. They vary state to state. So how does Kansas decide what screenings to perform on our newborns?
Yeah, that's a great question. So the federal government has set a recommended universal screening program and called the Rsv. So Kansas takes what they screen for from that list, and we are working to get all of those conditions onto the Kansas newborn screen.
So what's the next step if a child screens positive for any of some of these conditions? What's the next step?
It depends on the condition, but what may happen is that they may need a repeat test, a repeat newborn screen. They may need specific testing. The state has guidelines or algorithms that providers can follow, the primary care provider can follow to help make sure the newborn gets what they need. And then as primary care providers, we can reach out to specialists as we need to make sure we're doing what we need to do to keep the baby safe and determine whether or not they actually have the condition.
Dr. Lewis, you're Pediatric Cystic Fibrosis Program Director, and I want to ask you, what are some more common positive tests that might come back that parents don't really need to worry about?
Sure. So Probably, I believe still statistically, the most common test that it comes back that positive, that usually just a repeat test is needed and it comes back to be normal, is oftentimes the thyroid test. But there's also quite a bit of specific metabolic conditions that might be slightly borderline, or there's also, if the infant is maybe in the neonatal ICU and they're getting kind of in their nutrition primarily through IV at that point in time, that can kind of cause some of those tests to be slightly abnormal, and then gets repeated, and they understand, kind of the neonatologist team, for example, will know how to kind of help interpret that for the families. But I would tell you, the thyroid is the most common, but you need to always pay attention to if you get a letter or you get a phone call from your pediatrician, we need to do something.
That was my next question, is no news good news? We're expecting parents, nobody's going to go through each of these 34 different screenings, but once you get that phone call or letter, then you're going to follow up.
Absolutely, yeah. So, the state of Kansas, the KDHE, who owns this program, has really a tremendous amount of infrastructure to basically make sure no baby falls through the cracks. And those go with letters to those kids, families, as well as the pediatricians' offices they get phone calls if it's something that's kind of a critical value as well, to make sure that there's kind of communication there, as well as there's a little bit of an oversight group that I know that Dr. Bettinger heads also, to make sure that if there's something that we feel that maybe at the state of Kansas level, this kid still needs more testing, because these are some very complicated kind of conditions, and it's not common that most people come across those types of conditions. Sometimes they might get reassurance, and they need to be able to actually get a little bit more knowledge of this test is needed. I know Dr. Bettinger and her team in Topeka can make sure they reach out, provide specific education to those PCPs and families to get the testing they need.
I remember they would come in and check my baby for hearing. Is that part of one of the screenings? That is. Okay. Is there any screening that either of you, and I'll start with you, Dr. Bettinger, that you would like to see added that that we don't, or maybe futuristically speaking, is there something that may be added down the road?
Yeah, so we're actually in the process of adding one condition called X-linked Adreno Leukodystrophy, which is on that recommended universal screening panel, but that we don't do regularly at the state level. So we're in the process of doing that, and it takes anywhere from a year or two typically to go through the whole process.
Can parents ask for any additional testing if there's something maybe they've heard of or read? When you're pregnant, you go down the Google rabbit hole. And you've never heard that before. Right. Is there anything, if something pops into their head, do they need to ask a doctor about something? What's that like?
Well, so this is a tremendously regimented kind of testing, and so you saw there on the video, what's really pretty impressive is the amount of things that are being tested off a couple little tiny drops of blood that's put on a card that then gets mailed to Topeka, and then in Topeka that team starts doing testing. And so this is not necessarily a situation where it's like my family has a history of something specific.
Gotcha.
Those might be a little bit more directed testing to work with their primary care doctor for. But the great thing actually, honestly, about the state of Kansas testing program is it's free to families. It's one of the very few states now that still exists where this is done free and provided by the state. A lot of times these costs are passed on to either the birth hospital or to the families in some way. But one of the things that the state does is they do cover all of those fees, which is a pretty impressive thing nowadays.
Very impressive and very well needed. Cystic fibrosis is tested in that blood drop?
It is. It's been on there for about 10 years. And so as Dr. Bettinger referenced, this has continued to grow and add more things. And of course, that's kind of a combination of technology and testing. I think everybody probably understands as COVID first came out, it wasn't really a commercially available testing. And now you have all the in-home testing. And so it's kind of, when does the need for a certain condition meet to be tested, that the technology to test kind of comes into play, and how can you implement any therapy as well. But CF is now on there, and so the cystic fibrosis testing actually includes genetic testing. If somebody comes back positive for one test, we can then do some genetic testing afterwards. And it's kind of neat that we've actually got some of the most advanced of anywhere else in the country of how many genetic mutations we look at for cystic fibrosis.
What a relief and peace of mind for new parents, knowing that this is happening.
Yes.
So I have to ask you both, can't get too far in without asking you as we start kind of creeping towards flu season, what are we seeing in the clinics? What are we seeing when you're rounding on the floors? Dr. Benninger, start.
So we've been seeing a lot of the typical viruses that go around this time of year, things like hand, foot, and mouth, croup, that sort of thing on the outpatient side. Dr. Lewis, what have you been seeing in the hospital?
So we've definitely been seeing more RSV than's typical. Ever since the pandemic started, I think pediatricians, whether they're hospital-based or they're out in the outpatient setting, are still trying to understand a little bit of when do we get some regular seasonality, because the very first winter of the pandemic, flu and RSV were relatively non-existent. And then last summer, we had a tremendous amount of RSV. Hospital beds across the country were few and far between, due to such high volume of RSV babies that we had everywhere. We've still seen a couple cases of RSV here and there, which is not the most typical for a summer, but it doesn't even come close to comparing to last year. We've also seen a lot of asthmatics hospitalized who are very ill from Rhinovirus, which I know Dr. Hawkinson, as the ID expert, can tell you is super common, but it has definitely been kind of a pretty nasty strain of rhinovirus that's run around and caused a lot of asthmatics to be pretty sick if they're not like really on their asthma regimen.
So you talked about RSV. We spoke with one mom who just last week had a recent scare with RSV. Listen in.
We were alerted from our daycare facility that there was an RSV exposure, and then upon picking her up, I knew she wasn't feeling well, and we just kind of deteriorated. So we kept her home for the first couple days, and we just continued to monitor her, and by the end of the week we knew that she needed more advanced care. So then we went to an emergency room, and from the emergency room we're admitted, and then quickly from admission taken to the ICU just due to oxygen levels. I think the scariest part is just knowing that little kids can get so sick so quickly, and they can't communicate what's happening. And just knowing, you know, I've kept waiting for that wall that we would hit where she would start bouncing back. And it just seemed like that was a long time until we kind of started to see that improvement.
No parent expects a child with a runny nose or a cough or a wheeze to go from being at home to escalating to ER and then into ICU. Just any advice for parents on what to look out for? Because I have to tell you, you have explained to me the difference between flu and RSV, and you always have a great explanation, and I walk away going, I still don't know how to tell the difference.
Well, they're both viral illnesses, and so, but the big difference is that with RSV, a fair number of kids can get it kind of in their lower airways, and those are the kids who typically are going to do worse. And they really start to have an increased work of breathing. And, you know, I just will tell families, your baby is a massive snot factory on top of the fact now they kind of have that type of snot down in their lungs. And we don't have any medicine that really gets them to feel better faster, so it's very supportive care, which is, as you saw there for that little baby, it's supportive care through, so it's a lot of IV fluids and it's oxygen support and a lot of suctioning. Usually flu babies don't kind of produce so much mucus as what necessarily a baby who does with RSV. But I tell you, never doubt your parent sense. If you're like, this is not right, I just don't feel this is what's supposed to be going on, then you need to call your pediatrician's office. If it's after hours, there's surely going to be some mechanism that they can escalate things. But if at the end of the day you're like, my baby does not look right, I think they're sick, then you need to go to the emergency room. And I know a lot of times the emergency room kind of scares people because they're like, I don't want to wait in line forever. If you bring in a baby who is very much so having a hard time catching their breath, that baby goes very much to the front of the line, and things happen quite rapidly because you want to have everything as in a controlled setting as possible. So that's part of when you check into the emergency room. They do take a look at you. And so I would tell folks, don't wait, because if we get dehydrated, then it really kind of starts a cascade.
Okay, I'm glad you brought that up, because some people do hesitate going to the ER. They don't want to sit around for 10 hours waiting, and you won't do that in this case. So Dr. Benninger, if a parent brings in their child and they do have that trouble breathing, that also sounds a lot like COVID. So are you checking them and testing them for both RSV and COVID, or can you just spot that?
Yeah, so we wouldn't know which virus a baby has or a child has unless we do a specific test. In the clinic, we can do COVID tests, but we don't do rapid COVID tests, so they don't come back right away, but within a few hours. We can also do a rapid flu test. I'd defer to Dr. Lewis on what gets done on the inpatient floor here.
Yeah, so what, as most people who, even if you're not in medicine, you've started to hear all the differences between rapid testing and other versions of testing. And so what we can do in the hospital and even in the clinic, but like Dr. Bencher said, it doesn't happen, you don't get the results quite as quick, is PCR testing. So a lot of folks have now gone through kind of, that a little bit more invasive PCR testing for COVID. That exact same swab can be actually used to test for quite a few things, and so RSV and flu as well, with a much higher degree of accuracy, as well as a lot of other viruses too.
So the mom that we just showed you here, she was not brought here, but she was brought somewhere else and they did not test for RSV. Do you need to ask for an RSV test?
That's probably really going to be up to the conversation with each of those docs, helping take care of your kid, and nurse practitioners and PAs out there, because sometimes it's gonna, if you're positive for flu, for example, having the RSV test may not really necessarily add anything to it, except maybe a little bit of an extra bill for you, since we don't really, unfortunately, have a directed therapy for RSV. Flu, there is a little bit more you can do, obviously, with Tamiflu, but so. Kind of hard to probably have a blanket statement one way or another.
All right, we're talking newborn screenings today, but I had to sneak in that topic because it's very timely as we're back to school and back to daycare and all that stuff. Do we have any reporter questions on the line today? Okay, we do not, but we do have some good viewer questions coming in. Lauren wants to know, I did a genetic blood test when I was pregnant. What's the difference between that test and then a newborn screening? Is one on the mom, one on the baby?
Yes, so typically the genetic screening during pregnancy is on the mom. Sometimes the moms may end up doing more tests that are specific to the baby, but the newborn screening is for the baby and takes into account obviously the other parent as well. And sometimes babies have new mutations that their parents didn't have, and so it's still very important that the newborn have its newborn screening test done to get a full picture of what that baby's health.
All right. Monica wants to know if newborns are screened for COVID these days. And during the pandemic, when would you screen? If a mom had COVID?
Yeah, that's a really good question. So we don't routinely screen newborns for COVID. In the hospital, a newborn COVID test is the same or very similar to everyone else who gets COVID tested, which is the swab up quite far up the nose. Earlier on in COVID, the CDC and the American Academy of Pediatrics recommended screening babies or testing babies who were born to mothers with active COVID or thought to have active COVID before they discharged. That because, like Dr. Lewis was saying, we don't and didn't have a specific treatment for COVID in babies beyond doing supportive care. That was really a discussion between the provider and the parents as to whether or not they wanted to have that test done. I had some families that did want to do it because if it turned up positive, they wouldn't need to, the mothers wouldn't need to have that extra stressor of trying to prevent transmission of COVID to their babies by masking every time they were nursing, for example. But then other families that said, well, they could turn positive at any point. I don't want the swab on my baby, and so they chose not to do it.
All right, that's a good segue to get to our COVID count this morning. Let's turn over to Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Yep. Good Friday to you.
Yeah, it's good. Today we have 18 active infections, 3 in the ICU, 1 on the ventilator, 19 in that recovery period. And I would like to note from yesterday, we have some information that people, really like to hear about as far as our cases and vaccination status, age, etc. So yesterday we had 18 active infections as well. Of those, the age ranged from 35 to 93. And of those patients in the hospital, 3 had incomplete vaccine series. 6 were overdue for a booster, so that's half there that are not even up to date with vaccine. 6 were unknown, and only 3 were vaccinated. So hopefully that will help some people out because we know we get those questions as well, Jessica.
Yeah, people want to know how important are those boosters?
Yeah, absolutely.
We see that they are. Yep. How are we doing with monkeypox?
Monkeypox still in Kansas, very low numbers, single digits, 5. Obviously, you see there 53 in Missouri. We have 19,000, almost 500 cases of monkeypox in the United States. But again, what we have seen and I think is important is the trend of cases is down And we know that the vaccine is helping as well towards going to decreasing those cases. We have given about 130 doses of Jynneos vaccine here at the health system.
All right, this is not monkeypox or COVID, but another virus that is now making headlines. The CDC reports a handful of swine flu cases detected in humans in multiple states in the country. What do we know about this, and is there a vaccine for this?
So certainly no vaccine. We know that our influenza surveillance networks in the United States, but also worldwide, is very good. Certainly we get a lot of our data from Australia because they are about 6 months ahead of us. That is how we determine what components of the vaccine we will use, but there is no vaccine for that. But I think the thing to understand is the people that have been diagnosed, I think it was like 5, so it's just a handful, none of them were severe. They all had contact with swine, with pigs, such as fairs or 4-H events, things like that. So right now it isn't a major concern, and we still can treat that disease with oseltamivir, the antiviral for influenza as well. So right now not a big issue, but certainly we know that the surveillance networks are working overtime to make sure of that.
All right, so the CDC signing off on a new Omicron targeted booster shot.
Yeah.
They did this yesterday. So just tell us about that shot. Who gets it? When will it be available?
So right now they are going to be available for people 2 months after their primary series or 2 months after their last dose, which I think for most people it's going to be more than 2 months. For Moderna, it is going to be 18 and over. For Pfizer, it will be 12 and over. You know, you can mix and match as well if you need to. If you've gotten Pfizer before and they don't have Pfizer now, they have Moderna, so you are able to do that. The new boosters will contain the BA4, BA5 component, which is the same spike, but it will also contain that ancestral strain, the original spike as well. You know, we believe it will be beneficial. We know that the current vaccines still work very well, but that clinical data will be collected and analyzed as well. And we know it will be safe as well. Also, like Dr. Stites talked about on Wednesday, the influenza components are changed on a yearly basis. There's no safety problems with that. We expect that same thing with this booster as well. Just of note as well, the bivalent vaccine is just a booster at this point in time. If you have not received any vaccine, you will still be getting that original component vaccine, which again has continued to provide excellent protection against hospitalization, severe disease, and death if you are up to date with that.
Doc Hock, thanks for the update. Newborn screening in New York is leading to better outcomes for babies diagnosed with spinal muscular atrophy. Data published in the journal Neurology found the early diagnosis gave children access to life-saving treatments, most within the first 6 months of life. 6 weeks of life, that is. The state of Kansas does test for MSMA at birth. So, Dr. Lewis, in your work, how have you seen examples of access to earlier treatment having a positive effect on long-term health care?
Well, that's really the entire purpose of newborn screening, is that there's multiple very time-critical diagnoses that are needed. And so, as we kind of mentioned, if you get a letter, if you get a phone call from your child's doctor's office, this is something that you should be putting at the top of your priorities, is because we have seen multiple kids. Actually, I was just speaking to a mom yesterday who's has 3 daughters with cystic fibrosis, and the oldest, when she was diagnosed, the state of Kansas, and really nobody was at that point in time, had cystic fibrosis on their newborn screening. That baby she wasn't diagnosed till she was multiple months old. Hospitalization that really probably would have never been needed had we had known she had cystic fibrosis. Could have implemented a lot of those therapies right off the bat and then made better understanding of what things needed to be. But other sisters who came after were, well, one, it was much more high on our radar, but I've seen other kids who have had misdiagnosis for months and months and months, who, for whatever reason, there just wasn't a desire to keep looking for the diagnosis, even though genetically the newborn screening program had said, this child we believe has cystic fibrosis, please take that kid in.
Those months matter.
It's pivotal, and you know, it takes one very severe lung infection or like spinal muscle atrophy there's some of these things that you can't go back in time. And that's the most important thing to remember, is you can't go backwards for certain things. And no parent ever wants to have a coulda, woulda, shoulda situation. And the newborn screening program really gets that earlier diagnosis out there, because here there's multiple therapies we can do for an infant with SMA. That wasn't even really available, and SMA testing wasn't even available like 5 years ago, but it's happened. Severe combined immunodeficiency, all of these things that are out there now, those kids are on our radar to make sure that they're safe off the bat.
Doc, I have to ask you, how rare or common is it for someone to have 3 children with cystic fibrosis?
Well, it's a genetic condition, and so if both mom and dad are a carrier, so it's something we call autosomal recessive, which means if mom has one mutation and the dad has another mutation, and genetically, it's essentially 25% odds. And I tell everybody, those are like Vegas odds. Sometimes you win those odds and sometimes you don't win those odds. And so if mom and dad, and it's important to remember, that doesn't mean if you have one baby who does have cystic fibrosis, the next 3, if you were to have 4, won't. It's 25%
Every
each time. But those are odds, and sometimes odds play themselves out and they don't.
So when do those parents get those tests? Are those tests those parents got when they were younger, or to know that they have those, they're carriers?
The mom and dad would have known that they were carriers after the first baby was born. But I also think
not before? Not to know?
Not to know,
Okay.
correct. Yeah, but I also think it's important, that doesn't mean that people shouldn't have any more children either. I don't think that you should necessarily really drive this as family planning so much, because medicine is advancing pretty rapidly, like with SMA, and Dr. Bettinger can speak to a lot of the other conditions too, but for like cystic fibrosis, what I tell a family today who maybe their baby has cystic fibrosis is actually quite a bit different than maybe what I would have said 5 or 6 years ago, because we have complete earth-changing medications in the CF world now. And that's what it is in a lot of conditions now, that there's huge advancements in some of these things that we are seeing with medicine.
And Dr. Steit says with his CF patients, he goes, my conversations have really had to change. I actually have to say you have to start planning for retirement. You have to start, planning to live a long, long life. Those are conversations he was not having 20 years ago.
No, absolutely. I tell everybody, what you're going to read on the internet about certain things, that's not with a long history of some of these medicines being around. So outcomes sometimes just need to be thrown out, and we're going to rewrite history with your kids.
Dr. Bettinger, are these screenings that we're talking about this morning, are they optional? Do parents have an option, or are they required by the state?
They're strongly recommended by the state. Parents do have the option to opt out of them, and they can sign a consent form to defer the test that the state has put out. Whenever I've had families that are hesitant to have the newborn screen, I sit down with them, we talk through what their concerns are and the potential benefits to their child, and what it means if their child had one of those conditions and we missed it. And so far, knock on wood, every time I've been able to reach them, address their concerns, and they agree to have their baby tested.
When might you opt out? When is that conversation happening? Right after you have your baby?
At least here in the health system, it would be a conversation that we'd have up on the nursery floor. Some families, maybe elsewhere, maybe they think it through and they opt out ahead of time or plan to opt out. But it's really a conversation that I've had in the nursery just a handful of times over the last several years.
Okay. Dr. Lewis, we saw interest in people, taking their genealogy tests, the 23andMe, the, Ancestry. Newborn screenings give us a lot of great information, but is it important to test your genes later in life?
My approach to that is, if you have a family history that you're aware of something, and you know that there's a genetic component to whatever that condition might be, that really to go back to your primary care doctor to have those types of conversations. Unfortunately, every genetic test that we do, sometimes you get back information, and I'll tell folks, you can throw a big net into the ocean and catch something, but the question is what do you do with everything you catch? Is that a keeper or is that not? You get a lot of information back from some genetic testing that really is probably not of great utility, and so there's kind of big, wide tests you can do genetically, but there's very specific ones.
Right.
And so I think it probably oftentimes, if you're not having a kind of a directed focus of where you're going, yet sometimes you can kind of probably go down many pathways, but it's not going to necessarily have great yield for you. So kind of drive those conversations with their doctor. I think the 23andMe things are have picked up a lot of traction just because a lot of time people at home from COVID have had other things they do and track their genealogy.
They're
and
fun
some
and
of those things
interesting,
too.
but not reliable for
Right.
real health
But
concerns.
they're not the most necessarily diagnostic.
Right.
Like, for example, with cystic fibrosis, they do not, there are over 2,000 known mutations that can cause cystic fibrosis. They don't include anything close to that. And so sometimes I feel like it can actually provide some false reassurance that someone's not a carrier when actually they might be.
I want to get to some community questions that are coming in this morning. Anne says, since most babies found to be deaf are born into hearing families, are those families put in touch with anyone from the deaf community before they leave the hospital?
Probably not that quickly. We don't typically, at least on the nursery side, babies are only in the hospital for 1 or 2 days, and so we don't typically know at that point in time whether or not they have congenital deafness or congenital hearing loss. We do the screen in the hospital, and if the baby doesn't pass, then the baby will repeat the testing when they are a few weeks old at our outpatient audiology center. And so we don't know yet. When babies are diagnosed with congenital hearing loss, KDHE has a recommended set of things that the primary care provider is doing with the families, and one of those is helping connect them with other families who have children with hearing loss.
A word we hear sometimes with newborns is jaundice. Emily has a question. Does every newborn deal with jaundice of some level? Why do some kiddos need intervention and others can just go home and be treated by the sun?
I'm probably going to punt this one a little
Punt
bit.
it.
Dr. Bettinger does a significant amount of work in the nursery. I'm not so much. I usually get the babies who are readmitted to the inpatient unit. But yes, everybody has some version of jaundice. I'll let Dr. Bettinger hammer on that more.
Thank you, Dr. Lewis. I spent a lot of my time thinking about jaundice and taking care of babies who have different levels of jaundice. So as the viewer mentioned, there are different severities of jaundice. Almost every baby has some level of jaundice, or at least a bilirubin, which is the marker for jaundice, is higher than what is normal for the adult level. A baby's risk for having damage from the jaundice depends on a lot of factors, such as their gestational age, so how far along is the mom when they were born, and any other risks they may have, like infection or other things. And so we take into account where a baby's bilirubin level is at about 24 hours of life or 28 hours of life. We check it, we recheck it in the hospital if we need to before discharge. If the baby's level is high enough that we're concerned, it could be getting to where it may end up causing damage to the baby, then we start treatment, which are special blue lights that help drive down that bilirubin level until the babies are old enough to process the bilirubin on their own.
So John says he's 30 years old and he has no idea if he was tested for conditions at birth. Is that something he should follow up on if you just don't know what was going on 30 years ago?
What was tested 30 years ago is remarkably different than what it is now. It was like thyroid, something called PKU, something called CAH, sickle cell disease, and maybe I'm missing one other, but it was actually pretty slim testing options at that point in time. So those situations that would have been offered on the newborn screening when John was born, those would have not gone undiagnosed until he was 30 years of age. So I don't think you need to go hunting for your newborn screening from 30 years ago, because those, even then, the purpose of newborn screening was to catch things early before your infant would have been not treated and had some irreversible issues, or to be able to avoid some of the complications.
So you think John's in the clear?
I would say John's very likely in the clear at this point in time.
Okay.
That doesn't mean that's congenital, and I think it's important, that's congenital hypothyroidism. That does not mean like what is more standard of like what an adult has, or even like an adolescent, of having hypothyroid or hyperthyroid for that matter too. So that doesn't mean that you're not going to have thyroid issues in the future, but it meant for kind of irreversible brain damage that a baby could have with low thyroid. John didn't have it.
And John has to just accept that he's 30, and there's plenty of adult screenings coming his way, right? That he can take care of himself.
Yeah, but we'll defer to our internal medicine and family medicine
Right.
colleagues on that.
In 15 years, he gets his colonoscopy. So
Yeah.
all sorts of good screenings coming your way. Okay, so Dr. Hawkinson, I got a couple questions for you. Isaac wants to know, the new booster was just approved. When will it be available in all the drugstores you see?
Yeah, I know they have started shipping. Some places probably around the nation may have gotten some today, but that's pretty early. We know we are expecting our first shipment September 14th at this point in time. So I think it's just variable through the states and through those specific institutions. I would check with them, but I know that we will be getting our first shipment of boosters on September 14th.
Last couple of questions. What type of eye health screenings are done? Can you tell if a kiddo will be at risk of things like lazy eye or eye turning in the newborn phase?
Yeah, that's a good question. So it is very normal that newborns' eyes sort of go in all directions. I just saw one in clinic yesterday that I commented to the parent. It looks like he's a little googly-eyed right now. That's okay. It's really important that babies have their ongoing well baby care, and at those visits, the provider who's taking care of him or her is screening for things like that. And typically, it's later on in babyhood, maybe around 6 months, that if a baby's eyes are still turning in or seem to be wandering around, then we can do different tests in the clinic and then refer on to our ophthalmology colleague if needed for more testing.
All right. Just, if you could answer this, Jean wants to know, what special steps should pregnant women take when and if they get COVID? Just any advice?
Well, I'd probably defer that to Dr. Hawkinson over there, but I think quick contact to your OB.
All right.
Yeah, Dr.
Doc,
Hawkinson.
anything to add?
I would start before that. We have an abundance of data, well done studies that continue to support the fact that mothers who get COVID, mothers-to-be, do have higher risks of going to the ICU, of having complications, but those mothers that have been vaccinated and are up to date with vaccine continue to have better outcomes for both them and their babies. So it starts with talking with your OB-GYN, getting vaccinated, and after that, just as Dr. Lewis said, again, go back and ask those questions to your OB-GYN. See if what exactly is going to do. Most mothers obviously are going to be young, and so there probably won't be a need or benefit of Paxlovid, but really just talk with your provider.
All right, great conversation today. Let's get to our final thoughts. Dr. Lewis, get us started.
Be supportive of newborn screening because it's so expansive and it continues to grow with more and more technology that we're able to get. And I think a lot of times people will always want to know, what does my money go to behind the scenes? In the state of Kansas, we know it goes for newborn screening, which is a rarity now, and get your flu shot.
Keeping our future adults healthy. Don't opt out. No reason to opt out, right?
Correct.
Dr. Bettinger, final thoughts?
Yeah, so I echo what Dr. Lewis just said and what he said earlier, that if you are notified that your baby had an abnormal result or needs a repeat newborn screen, please get the recommended repeat screen or additional testing done to help keep your baby as safe as possible.
Dr. Hawkinson, send us into the long weekend.
Yeah, so I would agree with Dr. Lewis and what he said earlier. Let's let no baby fall through a crack. Just a little bit of play on words there. That's always good. But you know, we talked about some testing. Just like to throw this out to the audience. Multiplex PCR testing is what we do for influenza A, B, and RSV here in the hospital. Multiplex meaning there are multiple tests in that one. We also do a respiratory viral panel, which is a multiplex PCR, which includes 9 or 10 different virus and bacteria targets as well. And I think it does all start with continued screening, talking with your OB-GYN, talking with your pediatrician, not only influenza vaccine, but we know that there has been a case of polio here in the United States. It is a vaccine-derived isolate of polio. This is why it's so important to get all of those childhood vaccines. We have the benefit of living in generations before us, through those generations before us that had to deal with those types of illnesses, all those complications of illness, such as paralysis from polio and other things from different infections. We know how vaccines have helped significantly reduce all those complications and death from those diseases. It is quite important to get your children vaccinated against those things to protect your children, your family, and other people in the community as well. So I think not only influenza, but all of those childhood vaccines. Please go see the pediatrician, or even go to the local pharmacies if you don't have access to a pediatrician, and get your children and yourself up to date with vaccines.
Doc Hawk, thanks so much. Yeah. Finally, this morning, honoring the University of Kansas Cancer Center for becoming an NCI Comprehensive Center.
I, Laura Kelly, Governor of the State of Kansas, do hereby proclaim September 2022 as Comprehensive Cancer Centers Awareness Month in the state of Kansas, and I urge all citizens to join in this observation.
Kansas Governor Laura Kelly signed a proclamation yesterday marking this historic designation at the Cancer Center. The University of Kansas Cancer Center is now only one of 53 cancer centers in the U.S. with this title that is really simply considered the gold standard. In her proclamation, the governor says the fact that we are an NCI Comprehensive Center means more people in the region will have access to the latest research, treatments, and prevention for cancer.
You know, it's very heartening because over many years now, we've been in a lot of offices for the legislators and the governors, 5 governors, and really almost uniformly, we've had incredible support, and that support has been vital to who we are today.
In addition to comprehensive status, KU Cancer Center was awarded a 5-year, $13.8 million grant to support the center's research programs and shared equipment and resources. The University of Kansas Cancer Center has nearly 350 researchers and 150 disease-specific oncologists. So a huge congratulations to Dr. Roy Jensen and the entire team at the Cancer Center. Thank you so much for being with us today, and don't forget you can catch our updates by logging on to Facebook, YouTube, and on Twitter. Now we, of course, won't be here on Labor Day, but we will see you back here Tuesday. And as we return to our live updates 5 days a week, we are really looking forward to seeing you then. So go out and make it a great 3-day weekend. A 15-year-old boy suffers a stroke while at the gym.
Sometimes I slur my speech.
I'm Jessica Lovell, but the kid's quick thinking and his care team helped save his life. You'll meet them all Tuesday at 8 on these social media channels.
Subscribe to our morning medical update and open mics with Dr. Stites podcast. Now, everywhere podcasts are available.